has the 21st century.
I'm hopeless with technology, absolutely hopeless. Give me a computer and it'll play. So that's a really good start for us. The second lecture is going to be from Harriett Walter on a different subject, nothing to do with aneurysms, one would hope. And this is, you're from the Cancer Studies group, and you're currently a fellow in the Clinical Trials Unit, is that correct? Okay. So, Harriett,
so the screen's not working.
Doctoral Lecture. Thank you very much.
Still got it up here. Thank you. Good. So thank you very much again for asking me to come and present. And over the past couple of years, well, a few more than that now, about 4 years, much of our work, both in the clinical and laboratory setting, has been around the studies of Bruton's tyrosine kinase inhibitors. And in particular, we've focused on tirabrutinib, which is a second-generation selective BTK inhibitor. And what I'd like to just present this evening is some of the highlights of that work, and particularly focusing really on the clinical side and actually what that's brought to a lot of our patients here in Leicester. So to provide a bit of background, what BTK sort of first came into being really in 1952. And it was this gentleman who is Colonel Ogden, and he was a consultant paediatrician in Washington. And he first described and noticed in 8-year-old boys recurrent episodes of pneumococcal sepsis. And they were subsequently found to have a lack of B cells, and in particular immunoglobulin. But it wasn't until sort of 4 decades later that BTK mutations were first described. I should be able to. So BTK itself is a gene that lies on chromosome X and 659 amino acids long. It's got 5 different domains, and in particular, the important ones sort of that, in terms of the tirabrutinib are the kinase domain, to which it irreversibly binds, and also the pH domain where it connects to the cellular membrane. So what we've sort of discovered is that BTK actually plays a very critical role in terms of B-cell receptor signaling. It's important in amplification, diversification, and transmission downstream of the BCR, which is the B-cell receptor. And you can just see that's there. And in B-cell malignancies, BTK isn't mutated as such, but what it is, it's a functional target. So in 2009, it was the first time that we characterized ibrutinib, and subsequently clinical trials started with that in 2010. And ibrutinib was the first in class of the BTK inhibitors to reach the clinic. It was then in 2012 that the clinical trials started with tirabrutinib. And we can show you a little video. So this is BTK, and this green bit is where the drug actually binds to the cysteine molecule in the kinase domain. So if we think about both ibrutinib and tirabrutinib, what we have found clinically from experience is that tirabrutinib just appears to be a much cleaner drug to use, so that patients often describe a lot less toxicity. Whereas ibrutinib, they tend to get quite a bit of diarrhea, they can get some arthralgia, and also more problems with cytopenias. And really this comes down to actually the specificity of the molecule. So this is a kinome scan that you can do to find out how specific a drug is. And you can see this is for ibrutinib, and there's lots of red here. And that, in essence, means that it's not such a clean drug. Whereas on this slide here with tirabrutinib, you've got much less red. So that suggests that this is a much cleaner drug to use. And clinically, that's definitely the case. So this is the trial that a number of our patients in Leicester took part in. It was the phase 1 trial of the selective BTK ONO4059, as it was called then, which is now called tirabrutinib. And it was in relapsed and refractory B-cell malignancies. So there was a cohort for chronic lymphocytic leukemia and also a cohort for all non-Hodgkin's lymphoma. And in total, there were 9 dose escalation cohorts. So with a phase 1 trial, we start with a very low dose, 20 milligrams, because this is the first time that this drug is going into a person. And it's important that we try not to cause harm. So we start low and then go high. And we also had a BD dosing schedule, so that means twice a day. And that was in order to make sure that actually giving it once a day was enough and we didn't need to give it twice. We found out subsequently that once a day was adequate. In total, there were 6 centres that were involved, both in the UK and in France. And in Leicester, we had the highest recruitment. So we actually had 28 patients that were recruited in that time period. And to date, 7 patients remain on trial and extremely well. So this is just an example of the clinical responses that we were seeing. So this is a CT scan, and it's a slice essentially through a patient. And this patient has CLL, and they in particular have chemotherapy refractory disease, which means that they're really very difficult to treat. And this patient, after just 3 months on trial, you can see the CT scan looks really different. So all that grey is basically bulky lymph nodes, and that has just completely disappeared pretty much after 3 months. Again, we can look at sort of how well patients are responding on this trial. So 28 patients with CLL went on trial, and 25 patients were what we call evaluable. So we could actually assess how well they did on trial. And these patients were a mixed group of patients with CLL. So they had poor prognostic features, and in particular, we look at 17p deletions and also 11q and TP53 as well. And you can see that across the line, if you have, basically this is where your tumour starts, and anything below means that the cancer has responded. So you can see that all but 1 patient had a response. And these different colours represent all the different doses. So what we saw again was actually it didn't seem to matter how much drug, what dose you gave. They all just seemed to do extremely well. And this is, I think, sort of one of the first times that we'd seen such amazing results in this group of patients. So as I said, there was no obvious dose response that we could see, and this was also applicable to other patients with different disease subtypes as well. This just represents the progression-free survival, so basically how long patients stayed on the drug and without further progression of their disease. So you can see that the blue line here represents patients with chronic lymphocytic leukemia. The green in the middle here represents patients with mantle cell lymphoma. And the red line here is the patients that have a diffuse large B-cell lymphoma. All these patients have been treated before, so they are in a difficult position when they go on trial, that there aren't standard options that we know that will produce a good effect in terms of disease control. So just highlighting that fact, we found, and this was back in 2016, so these figures have now extended. We found that those with CLL stay on trial for an average of 874 days, mantle cell over 300, and diffuse large B-cell, unfortunately, they were not able to stay on trial for as long. They stayed only on for 54 days. And as a result of that, a lot of my laboratory studies were focused and continue within the laboratory group at the moment to be focused on trying to understand why is it that that group don't do as well, and what is it that we can do to try and improve that outcome. In terms of toxicities, so in total there are 171 adverse events that were reported, and the majority were grade 1 and grade 2, both across in CLL and the non-Hodgkin's group. The main toxicities that we tended to see with ibrutinib tended to be arthralgia, diarrhea, and cytopenias. And we didn't find that that was the case with this drug. We found that there were much lower rates of toxicity, and we didn't see, as I said, other toxicities, in particular atrial fibrillation and bleeding events, which again have been seen with ibrutinib. But clearly what we saw from the trial was that this treatment was not enough for diffuse large B-cell lymphoma. So here's a picture, and none of our patients mind this picture's been shown many times, of some of the patients on trial who did incredibly well. And of course, a few more that are looking very relaxed in clinic. And you'll be pleased to know they're back at work, because there's no slacking when you're on the phase 1 trial. So thinking about really, as I said, trying to understand what we're seeing in the clinic and then trying to see how we can do that better. we are really lucky in Leicester, and I think we're one of the very few sites whereby the hospital is actually so close to the laboratory. So it's about a 10-minute walk, and that's fine. It's nice in the summer, not so nice in the winter. You can probably do a bit quicker if you run, but essentially it's a 10 minutes to get the samples back to the lab, which really means we can translate what we see in the clinic to the laboratory. So what tends to happen is that we'll see patients in clinic, and we'll ask them and consent them to basically providing a blood sample or perhaps to donate some of the tissue from a biopsy. It then goes back up the road to the lab, and from that we've got several options. We can try to generate cell lines, we can try to derive patient-derived xenografts, we can do some sequencing, so we can look at RNA sequencing, whole exome sequencing, immunohistochemistry, and also some drug screening as well. And from that, we can put all that information together to really try and select which drug to give which patient, and if they should have a combination as well. So these are just the next few slides. I'll take you through some examples of how actually we've managed to do that in the clinic. So this graph is of a patient who is actually treated on the phase 1 trial, and up here you've got their lymphocyte count. So it's a patient with CLL with TP53 mutant disease, which means that they are difficult to treat. So the lymphocyte count starts here, and then immediately after starting the drug, what you tend to see is an increase in their lymphocyte count. And this is commonly seen with this class of drug. And it doesn't mean it's not working, it's just that we see you get an egress from both the bone marrow and the lymph nodes. So they had about a 1.8-fold increase, and then over the course of about really nearly 2 years, it finally comes back to baseline. Unfortunately, after 30 cycles, they then began to see disease progression on a scan. So we, at that stage, then looked for the presence of BTK and PLC gamma 2 mutations, which are commonly seen with this drug. And this patient didn't have those mutations. So what we did then was to escalate the dose up to 600 milligrams. And again, what you can see is this increase in the lymphocyte count again. And the patient continued to respond for over another year. Unfortunately, then they did progress at this point in time and went on to subsequent treatment. The reason that we decided to escalate was partly because the patient was actually treated at what we found to be a subtherapeutic dose subsequently. So they were one of the first patients to go on trial and treated in one of the early cohorts. However, we then found that 40 milligrams wasn't enough to inhibit the BTK. And so we knew from then that actually 80 milligrams was needed. However, we knew we'd get one chance at doing this, and patients hadn't shown toxicity, so I'm afraid I went for 600 on that one. Another example of really how, again, we can take patients and try and understand what's happening, why they're responding. So these, again, were patients on this trial, all with CLL that we took, and we asked for the blood samples to be sent from other sites as well. So these were blood samples that were taken pre-patients going on the trial. And we looked and we conducted some sequencing using a targeted sequencing panel that was designed in collaboration with Sal and also with Sistemas in Valencia. And Sandrine did a lot of the sequencing work here. And we basically found out what type of mutations these patients had. And we looked for the common ones on this panel and also some novel ones as well. So what we found was that 9 patients had a TP53 mutation. Then we had 8 patients with an SF3B1 mutation and 7 patients with a Notch1 mutation. And in total, in overall, our conclusion, although it was only small numbers and we couldn't do any formal statistical analysis, it didn't appear that the particular mutations prevented patients from doing so well on trial. It actually seemed that everyone seemed to respond irrespective of the mutational spectrum. And this was quite unlike what was shown with the Bruton, whereby they showed that TP53 mutations and 17p deletions were more important in terms of predicting outcome with a targeted inhibitor. So this patient has quite an unusual disease. So they have got a primary cutaneous diffuse large B-cell lymphoma. So that's a very small group of lymphomas and makes up about 20% of the cutaneous type. This patient was shown to have very high BCL2 expression on immunohistochemistry. And so subsequently, as a result of that, we applied for compassionate use of a drug called venetoclax, which is a BCL2 inhibitor. And what we saw when this patient started on drugs, so this was pre, and then this was a week, 24 hours after this was, it had significantly reduced in size. And then 2 weeks later, the lesion had completely disappeared. And this patient had a complete response on immunohistochemistry and also on PET scan. So on the PET scan, you can see initially you've got a hot spot here, and subsequently that has resolved. And they responded for over 18 months. So although it's only sort of patient study of one patient, it just shows you that actually by understanding what the biology of the disease is, we can then actually offer patients a much more targeted approach. So one of the big things is that, well, can we improve on standard chemotherapy? Can we make that a thing of the past? And actually, for the first time, we are beginning to see that perhaps this is the possibility. One of the advantages of having a chemotherapy-free regimen is that actually the toxicity is much less. And for patients, they can pretty much live a normal life. So this is an early phase study again, in which Leicester played a big part, the lead recruiters in the whole of Europe. And these patients were treated frontline with venetoclax and obinutuzumab. So venetoclax is a BCL2 inhibitor, and obinutuzumab is a newer rituximab, essentially. And these patients had either had no treatment before, or they'd had multiple lines of treatment. So it was an approach that we could offer to patients at all stages of the pathway. And what we found as a result of that was that patients of, I've just seen someone last week, 3 years down the line, is completely free of disease. There's absolutely no disease that we can detect on peripheral blood on minimal residual disease. So as if, the excitement wasn't enough about what we're doing in the clinic. Well, it hasn't always been sort of gone quite how we have liked it to do, and I think that's the nature of clinical practice. So this one was an unfortunate event. We did a trial with acalabrutinib in Waldenstrom's, and I'm afraid this is tiger lily, although it's not quite tiger lily because I didn't have written informed consent, so I had to borrow a picture. But this is tiger lily, and she had a midnight snack of acalabrutinib. She got hold of the patient's tablets and ate 1.5 of these. And unfortunately, this does seem to have a bit of undesired effects. And she actually got expelled from the cat class the next day. And I was told that she was really a very well-behaved cat. So that was not so good. And I've never quite worked out how Adrian and Mo, our pharmacists, kind of explained this one when the drugs didn't quite count back in. However, you'd be pleased to know that there was no harm to the cat in the long term and that they're fine. And then, also, our patients are actually really brave, and I just want to sort of highlight that fact because this was a patient who had never had treatment with CLL, for their CLL, and so they were treated frontline, and the reason, she was adamant that's what she wanted. She didn't want to risk the toxicities of chemotherapy. She also had a Notch1 mutation, which meant that actually she may get less benefit from the standard frontline treatment that she would have been offered. So she wanted to go on this trial. So she had her first dose of obinutuzumab, and as a result, she actually developed sort of poor blood clotting, or what we call coagulopathy, and her platelet count went very low. So she had to come into hospital and be sort of managed with best supportive care, so she had blood products. Unfortunately, after a couple of days, she really did make a full recovery. But of course, it would have been the time when Martin was on holiday, and I'm afraid he did got woken off his sunbed at that point. And then, some of the things we're asked to do in an early phase trial, poor Linda spends hours working up all our amendments, and I'm never quite sure if she's forgiven me for this one, for the fried breakfast amendment. And the number of emails involved around how much fat's in a hash brown, particularly which way you cook it, and how many hash browns make 120 mils. So we kept her busy on this one. So, what can we deliver and deliver well here? And I think, you know, we can deliver. We have the expertise here to deliver first-in-man phase 1 trials. We've got an excellent team, both sort of, you know, clinical facing and all the setup that goes into these trials. We're also able to do reverse translational studies, so we can take our patient in clinic and after they've had the drug, we can then try and understand why they've responded or why they haven't responded. And we're also good at working with pharmaceutical companies. So a lot of the work, alongside the clinical work, there's a lot of work that goes on up in the Dyer laboratory, working with these molecules, both in cell lines and also using patient samples, again to try and understand why and who should have these drugs. And I think so we really can offer a personalised approach to cancer treatment in this manner. So what makes it possible? I think particularly a dedicated early phase clinical trials team and facility, which we have down at the hospital. They never seem to mind when they have to do PKs at 8 o'clock on a Friday night or stay the night to look after the patients. The Research Institute, of course, in which all the laboratory studies currently take place. And of course our patients and referring clinicians, because if the patients weren't willing to take part, then we wouldn't actually be able to try and improve their care and understand what's happening. And the clinicians that refer as well, because we actually have a huge catchment area. So we do have patients that come from Manchester, from London, from Norwich, and also within the Midlands as well. So it's not just local patients that we see. So I think just some of the important people, really, and I'm afraid that I haven't got enough room, really, to put everyone on there. They're all really key in making this happen. And of course, sort of Martin up here and Sally Hannah, his wife, who never minds when I ring on holiday. The set-up team are the lead nurses, Sarah, and the haematology nurses as well, all the people that do the work in the background, and also our laboratory team as well in the institute. So a huge thanks really to Scott Worsby that funded me for 3 years for my work, and subsequently to our UK that fund part of my salary as well. Martin and Sandrine and all the people that are involved in the institute currently and in the past. A number of collaborators in the university, the patients and their families, everyone on the Hope Clinical Trials Facility and the Hope Annex, and clinical colleagues in the department.
So you must be burning with questions, if not just about the cat. Was that really the cat's eyes? Seriously?
Yeah.
No, you're joking now.
No, I'm afraid I didn't get a picture of the cat.
Some questions? Any questions on the floor?
I have a comment and then I've got a scientific question as well. The comment is, it was a great pleasure for me to see the Ernest and Helen Scott Institute working out as Helen Scott Hope, because Martin Dyer and I brokered we had some very interesting, because she was a barrister, she made a lot of money, her and her husband. Donated did actually die to set up this institution, and I remember saying to her that, and she said, well, what's it actually going to do? And my response was, well, what it will do is it will provide research opportunity for bright young people to develop their talents at Leicester within the general field of hematology. And it's great that seeing you here tonight and to acknowledge the support that Helen put into the unit. The scientific question is this, that you chose to use one of the tyrosine kinase inhibitors. I mean, there's so many examples in cancer therapy where 2 agents are better than 1.
Yeah.
Have you gone as far as trying the other one, which I can see has more problem with toxicity, but perhaps you could use it lower dose combined with the one that you put most of your effort into?
So Bruton got there first in terms of the market, so the early trials, and it is a lot further on in terms of its development. So it now has a license for use, ibrutinib, in the clinic, essentially. There's never been a head-to-head comparison of ibrutinib and tirabrutinib, which we've worked with, but there has been, and there are ongoing sort of studies comparing ibrutinib with acalabrutinib, which again is another second-generation tyrosine kinase inhibitor. So it's a crowded market. We've worked with all three in studies, and what we found really is that the toxicity is just so much less with this molecule. It's really
You're
interesting.
still losing some patients at the end, aren't
You
you?
do,
And
you
whether
do.
you would lose fewer or is it go more along the relapse or complete remission route
Yeah.
with two agents than with one.
So they both bind to the same cysteine, and because when they sort of at the point of resistance, particularly in CLL, it's less clear than resistance mechanisms in mantle cell and diffuse large B-cell lymphoma, but the cysteine can become mutated, so that therefore actually adding in another tyrosine kinase inhibitor to the same cysteine, it would not produce effect. But studies are ongoing about looking at a different BTK inhibitor which doesn't bind to that cysteine. So in those that have progressed on the commonly used BTK inhibitors.
Thank you.
We've also done another phase 1 trial which has used this drug in combination with a SYK inhibitor and a PI3 kinase inhibitor as well. So patients are still currently on that. It's close to recruitment, but we haven't got any long-term data from that.
Just a final comment. The questions that Helen Scott asked Martin and myself were much more difficult than one I've asked you tonight. She's a very, very clever woman. Yes.
So you showed that the CLL patients, the mutation spectrum didn't actually have any effect on how effective the tyrosine was. But with the diffuse B-cell lymphoma patients, what was the mutation spectrum? Did that have an effect on the efficacy?
We know that in terms of diffuse large B-cell lymphoma, if you think about it broadly, it's easier to just think of two groups of them. There's the germinal centre and the activated B-cell, so ABC and GCB. That's the easiest, the short term. So the ABC group, which are dependent on BCR signalling, so B-cell receptor signalling, are the patients that were allowed to go on this trial, because we knew that actually the GCB group weren't dependent on that signalling pathway. So actually giving them a drug, it just didn't work. And they realised that quite early on with the Bruton. But having said that, it's not quite as clear cut, because actually there was one patient that went on a trial with acalabrutinib that was a GCB, and they went on because the local treating physician thought they were an ABC, but actually they were a GCB, and they stayed on trial, I think, the longest. So it's clearly not, we don't understand that which ones tend to, we can't predict, I think, is the answer at the moment, which ones are definitely going to respond. We think that the ABC group are the ones to target, and if you look at the majority, then that's the right thing to do. I think we also don't understand why some of that group don't respond at all, and why the resistance sort of sets in before even 2 months on trial.
I have a question. So, the typical patient presents and they go into standard chemotherapy, correct?
Yeah.
How do we fast track the patients to getting what appears to be a better treatment?
I think it is a difficult thing, because I think it depends very much, and clinicians, I think, actually are generally very good at trying to offer their patients all options, particularly in the large hospitals, so where we do have access to trials. But it is about educating, and we try and work sort of very closely with all the treating physicians in the hospitals and through the MDTs to let them know what trials we've got available, so that if they have a patient that they want to refer for example, that trial, the frontline trial, we could then see them, even though they're out of area, to have that discussion. I think there's some clinicians perhaps don't feel comfortable putting a frontline patient, patient that's treatment naive, which would actually do very well if they have standard chemotherapy potentially. They may not feel comfortable to refer them at that stage. But I think patients are increasingly asking as well about, what options are available for me aside from this.
So this is going to go on the web, just so that you know. Any further questions?
So almost all of these malignancies have more than one avenue of pathway.
Yeah.
So are you surprised that one pathway, one molecule, small molecule, is really having this effect?
Yeah, I think it is surprising, and it highlights again sort of the difference between diffuse large B-cell lymphoma, which has it's a much more it's actually the best way to describe it. It's much more sort of aggressive, more rapid turnover of cells. So therefore, I'm not surprised that they do less in terms of staying on the trial. And CLL tends to have a much more indolent cause. I think it's strange that this drug doesn't cause more side effects. I think turning that question slightly around a bit, because if you think you're putting a major block in the pathway, and you think also about the young patients that have pneumococcal sepsis, so why don't these patients have no B cells? Why aren't they all really unwell on this drug? And again, that's not clear.
Okay. Thanks very much. So, Harriett won the PhD prize, but seems to have got Professor Lauder with us at the front. Can I shamelessly get you to do the presentation again, please? This is the magic envelope. I generally have no idea what's in it, but when you go to the hostelry afterwards, you need to follow the envelope. So would you like to...
That's very good, yes, and congratulations to you. What you probably won't know is that I lost my sister at 43 with an aggressive form of lymphoma, and it's the kind of work that's being done here now, and I think about it all the time as to with the kind of benefit of the kind of progress that's been made over the last few years in this personalised medicine. She might still be with us, but that's life, isn't it? Yes. Thanks so much. Brilliant talk. Actually understood more of yours than the surgeon talk.
I'm sure you've heard two really fantastic lectures, very different, different topics. Hopefully it's stimulated a bit of conversation. There's some fantastic nibbles outside, but as you know, there are some great local hostelries just across the side of the park. So thanks very much for your attendance, and enjoy the rest of the evening.